Hi everyone, thank you for the introduction. I'm Gil Shammai from the Geometry Image Processing Laboratory at the Technion in Israel, headed by Professor Ron Kimmel. Let me start. So, genomic tests have changed how we make treatment decisions in hormone receptor positive, HER2 negative breast cancer. Among them, the Oncotype DX test is the only one currently recommended by the NCCN guidelines. It's predictive for chemotherapy benefit. The landmark TAILOR-X study randomized patients to chemoendocrine therapy versus endocrine therapy in order to evaluate chemotherapy benefit across different Oncotype score groups. And following that, patients with a score of 26 or above are today recommended to receive chemotherapy with some adjustments based on nodal status and menopausal status. So genomic tests like the Oncotype DX are very useful, but they are also very costly and time-consuming. In developing countries, less than 5% of the patients use genomic testing. Instead, treatment decisions are based on clinical risk usually. This leads to overtreatment. For example, in India, about 85% of these patients receive chemotherapy compared to only 20% in the USA. So our goal was to predict the oncotype score directly from biopsy images stained with hematoxylin and the eosin, because this approach could offer a much more affordable solution and faster, and especially useful in places where genomic testing is less accessible. We made use of a foundation model pre-trained on 170,000 H&E slides. Each slide was first segmented into tissue and background, and then divided into small image tiles. The model then extracted image features from these tiles, and then we used the transformer multiple instance learning model in order to predict the slide-level oncotype score from these image features, together with basic clinical variables. So this is kind of a multimodal model. Then we fine-tuned and validated this model on patients from the TAILOR-X trial. On TAILOR-X test set, survival stratification was comparable between the AI score and the oncotype score for distant recurrence-free probability, as well as for all other endpoints that we tested. Survival stratification was also comparable across different patient subgroups, including pre- and postmenopausal patients. We next evaluated how the AI risk relates to chemotherapy benefit. Our model stratifies patients to low, intermediate, and high risk groups using predefined cutoffs. For postmenopausal patients, those with low-high risk had no chemotherapy benefit. In contrast, premenopausal patients with high AI risk had a clear benefit, and this makes our model the first evidence-based predictive test in breast cancer based on digital pathology. We then validated our model on additional 6 independent external cohorts from Israel, Australia, and the USA. These cohorts contained real-world data from a variety of patient populations, sample sources, and scanners. And the results showed consistent performance accuracy for prediction of oncotype score, as well as for prognostication. This shows that this foundation model approach can be transferable to new data, which is very important. We also used a calibration approach that did not require genomic data for this task. Finally, we wanted to evaluate the impact of this model in developing countries. So we measured the clinical risk of the patients in TAILOR-X using the established MINDACT criteria. And then we observed the patients that were reclassified from the clinical risk by our model. We saw that some patients with low clinical risk were reclassified by our model to high AI risk, and these patients had chemotherapy benefit. In contrast, and more importantly, about 30% of the high clinical risk patients were downgraded by the model to low clinical risk, having no chemotherapy benefit. And this can be very impactful in places where chemotherapy decisions are based on clinical risk, and especially significant for reduction of overtreatment. So we are now initiating a clinical trial in India in order to further validate this model. Thank you very much.